Endoscopic Diagnosis and Management of Non-Variceal Upper Gastrointestinal Hemorrhage, NVUGIH, European Society of Gastrointestinal Endoscopy, ESGE Guideline, Update 2021. Introduction. The most common causes of acute upper gastrointestinal hemorrhage, UGIH, are non-variceal. These include gastric and duodenal peptic ulcers, mucosal erosive disease of the esophagus, stomach, and duodenum, malignancy, Mallory-Weiss syndrome, Dieulafoy lesion, other diagnosis, or no identifiable cause. This ESGE guideline focuses on the pre-endoscopic, endoscopic, and post-endoscopic management of patients presenting with acute non-variceal upper gastrointestinal hemorrhage, NVUGIH, specifically peptic ulcer hemorrhage. Main recommendations. ESGE recommends in patients with acute upper gastrointestinal hemorrhage, UGIH, the use of the Glasgow-Blatchford score, GBS, for pre-endoscopy risk stratification. Patients with GBS of 1 or less are at very low risk of rebleeding, mortality within 30 days, or needing hospital-based intervention, and can be safely managed as outpatients with outpatient endoscopy. Strong recommendation, moderate quality evidence. ESGE recommends that in patients with acute UGIH who are taking low-dose aspirin as monotherapy for secondary cardiovascular prophylaxis, aspirin should not be interrupted. If for any reason it is interrupted, aspirin should be restarted as soon as possible, preferably within 3 to 5 days. Strong recommendation, moderate quality evidence. ESGE recommends that following hemodynamic resuscitation, early 24 hours or less upper gastrointestinal GI endoscopy should be performed. Strong recommendation, high quality evidence. ESGE does not recommend urgent 12 hours or less upper GI endoscopy, since as compared to early endoscopy, patient outcomes are not improved. Strong recommendation, high quality evidence. ESGE recommends for patients with actively bleeding ulcers, F1A, F1B, combination therapy using epinephrine injection plus a second hemostasis modality, contact thermal or mechanical therapy. Strong recommendation, high quality evidence. ESGE recommends for patients with an ulcer with a non-bleeding visible vessel, F2A, contact or non-contact thermal therapy, mechanical therapy, or injection of a sclerosing agent, each as monotherapy or in combination with epinephrine injection. Strong recommendation, high quality evidence. ESGE suggests that in patients with persistent bleeding refractory to standard hemostasis modalities, the use of a topical hemostatic spray or powder or cap-mounted clip should be considered. Weak recommendation, low quality evidence. ESGE recommends that for patients with clinical evidence of recurrent peptic ulcer hemorrhage, use of a cap-mounted clip should be considered. In the case of failure of this second attempt at endoscopic hemostasis, transcatheter angiographic embolization, TAE, should be considered. Surgery is indicated when TAE is not locally available or after failed TAE. Strong recommendation, moderate quality evidence. ESGE recommends high-dose proton pump inhibitor, PPI, therapy for patients who receive endoscopic hemostasis and for patients with F2B ulcer stigmata, adherent clot, not treated endoscopically. A. PPI therapy should be administered as an intravenous bolus followed by continuous infusion, e.g., 80 milligrams, then 8 milligrams per hour, for 72 hours post-endoscopy. B. High-dose PPI therapies given as intravenous bolus dosing, twice daily, or in oral formulation, twice daily, can be considered as alternative regimens. Strong recommendation, high-quality evidence. ESGE recommends that in patients who require ongoing anticoagulation therapy following acute NVUGIH, e.g. peptic ulcer hemorrhage, anticoagulation should be resumed as soon as the bleeding has been controlled, preferably within or soon after 7 days of the bleeding event, based on thromboembolic risk. The rapid onset of action of direct oral anticoagulants, DOACs, as compared to vitamin K antagonists, VKAs, must be considered in this context. Strong recommendation, low quality evidence.